So Eric Heyman and Eric's on my service right now, and literally I said, let's just take the last month of the service and let's just go over real life stuff that's happened, and go over kind of, how do you manage complications, and what do you do when you have them. And so we're going to go through some cases, and then I'll tell you what we did, and then I also want to illustrate some points, because I think it kind of brings up a lot of the issues that we talked about today, like biomechanics, pelvic fixation. Juan was talking about MIS surgery. Jeff Rose showed some pretty cool MIS cases. And so this is actually an interesting case. And this was a 60-year-old female who had an MIS procedure. And I think it was David showed a couple nice MIS cases. And, it's very difficult to put in pelvic fixation if you're doing percutaneous procedures. So this 60-year-old had a very nice, actually very good correction done, minimally invasively. And about 2 weeks after surgery, she started having increasing back pain. They got plain x-rays, and things looked okay. Maybe the distal end of it was an issue, but she actually was doing fine. So I'm just going to pick on Derek over here. So Derek, what do you think, just looking at the plain x-rays and then the CT scan? It looks pretty good, doesn't it? I mean,
the sagittal balance is nice, and without the numbers, it looks like they have pretty good sagittal correction. It just looks like it's hard to tell on the X-ray that the S1 screw pulling up.
yeah, so we were worried about that, and we got a CT scan, and the S1 screws look fine. I mean, it's not really that bad, but again, you're on call, and she said, Dr. Derek, my back really hurts. It's much more severe than when I got discharged home.
And there's no fractures on the CT?
No fractures.
Did anything happen?
No, she just started having more back pain. So what was interesting on the scan, she laid flat. So the S1 screws are they look like they're going in, but they actually had pulled out. And you can see them pretty nicely over there. And again, this is kind of the stuff we talked about earlier. If you actually look at her sagittal balance, they didn't get a complete correction. And so she's kind of tilting forward. And then you can see, the weakest screws here are going to be probably your S1 screws, because it looks like she's got a little osteoporosis and she's got scoliosis. So here she had this beautiful MIS procedure done. She's a month out, and then we have to break it to her that the screws are coming out. And, at that point, what do? You have all these stab incisions on the side. So what would you do next? Would you do an open midline, or would you just go back in and revise it through the percutaneous screws? And she's an airline steward, so she's really worried about what things are going to look like.
I have to measure and see how much more correction I would want.
Okay. So you'd get more X-rays and try to figure out what you want to do.
Right.
That's a good answer. So we actually saw her, and this is what we ended up doing. And she had really severe bone, and I actually had a hard time deciding. And intraoperatively, we decided, we're like, you know what? We probably should call plastic surgery, because the S1 screws and the L5 screws were such an angle, and they kind of had come out. I was a little bit worried about getting everything nicely closed up. So intraoperatively, Eric and I called the plastic surgeon, and we have one here at Swedish, and he came in and did a beautiful closure. But, it's tough because, her bone is it was horrible. It was like butter. And again, I thought we got a pretty good correction, but I'm sure something's going to happen at the distal end of this. And we were kind of trying to decide whether to put in hooks and we ended it at T6. So I initially had planned to go to T4, and we put in a total of 4 pelvic screws. And so after surgery, and again, this is what's nice is, so after surgery, she's about to get up and walk around, and she goes, Dr. O, my left leg is a lot weaker than it was before surgery. And I looked at Eric, and I'm like, shit, what did we do? What happened? So Eric's very smart. He said, let's scan her. And so we got a CT scan, and I kind of zipped through it, and I said, oh, everything's fine. But then if you look at the foramen, at the L3-4 foramen, in fact, you can see there's a little bit of foraminal stenosis there, and it correlated totally with her left anterior thigh weakness and numbness. And then when you looked at the rod was a little long too. So, do we take her back? This will be her 4th surgery in like 6 weeks. So what would you do, Derek? Steroids and more PT?
It's pretty tight, so if I take her back.
You would take her back? Okay. Now, again, you had plastics close the wound. It's Sunday. Her sister's in the room. She's like, really? You guys just did this massive operation. So we did this, and this is true, we kind of did a stall ball. We go, we'll give you some steroids, do some PT, see how things go. It's hard to take someone back right away psychologically after you just fillet them open and convert an MIS procedure. So the real life story is, you don't want to break bad news like right away. And that's kind of what we did. I mean, I went over her scan. I said, look, this is what I think it is. But, maybe, and I thought, and sometimes it happens, a long case, maybe there's some femoral nerve issues. Let's see how you do with PT. So we did steroids. We kind of got her up, gave her a couple days. And then she more or less was like, you know what? I think this is probably from what you were telling me, and let's go back. So for patients, it's easier to kind of swallow them. You're honest with them, which we were. And we said, look, these are your options. And then you kind of let them make the decision rather than saying, look, we're going to take you back. And she actually got, Eric, didn't she get better right away? Yeah. So she went home like post-op day 4. From a T6 to pelvis, her weakness went away immediately. And of course, she was in a lot of pain just because of the surgery, but the neurologic deficit reversed quickly. So the take-home lesson on this is if you do a big case and you have a complication, don't ignore it. Get a scan. And then I always bounce stuff off my partners. So Jeff Rowe, Jens, because as a surgeon, the number one thing you'll do on your own patient is denial. I mean, you're going to do everything to say, and even Eric, I was like, oh, she'll be fine. Give her some steroids, But this is, and again, I think this is what's good for you guys to learn. As David said earlier, in clinic, most of what we do is tell people, no, you don't need surgery, and we rehab and we do PT. The main emphasis of this weekend is to teach you guys and tell you how and when to operate, but also to learn how to manage complications. And again, this is like 1 month's worth of complications on my service. So we could have actually done more cases. And then there's the distal end of the rod. So we cut the rod, took her back, shortened the construct, and she went home post-op day 5. This is another patient that we had on the service, and she actually had, you can see there's a little lesion there. So Yev, so let's say you're on call with me, and you see this. What do you think? What do you think's going on?
Do we have a contrast scan?
We did get a contrast scan, and it didn't really enhance. Do you want to push your button so that people can hear you? Okay, so maybe, and they don't really doesn't enhance.
And there's no history of trauma.
Not really. She's having more numbness and groin pain, and she's having a lot more. So when they do PVRs on her, so post-void residual, she has about 1 liter in her bladder, and she can't fully empty her bladder.
Yeah, I mean, I think she needs surgery. It's probably a osteoporotic fracture, given the quality of the bone on the CT scan.
Okay.
You could fuse 2 to 3 levels above and below, and then push the bone down when you're in there with a decompression.
So you would do corpectomy, put 2 screws above, 2 below.
I mean, not a full corpectomy, just a partial to push the bone away.
And then how about down below? Do you see anything at L5S1 that you might be worried about?
She's slipping down, and if you create that construct, you're going to put more stress on that level. So there's definitely some justification to maybe do a T-lift and extend below.
So you're going to go T9 to the pelvis, and she's really doesn't want to have surgery.
You could offer the smaller procedure with the understanding that in the future there might be more risk of adjacent level disease at L5S1.
Okay, that's a great answer, because that's what we ended up offering her. And then she mobilized, I think, post-op day 1, she was getting around, and this is on her scout film on her CT scan. And in our hospital, we don't have EOS, and it's very hard to get upright films on patients. And so we do a CT scan on everyone. So it's like a poor man's plain X-ray, but they're laying in bed flat, so it's not truly upright. So her scan looked great, and then she started mobilizing after surgery, and she did not really have any symptoms at all. She actually was doing great. And we looked at that, and I was like, that cage looks funny. That doesn't really look normal. And then you can see that if you compare this X-ray to the fluoro images during surgery and the CT scan, those screws have moved just a little bit. You can kind of see it kind of windshield wipered. And so, this is the other point. When you do get imaging, don't rely on the radiologist to tell you what's going on. Really look at it carefully, especially if you see stuff that doesn't look right. So the radiologist didn't read this. It's like you order the film, 48 hours, they go, post-op X-ray, hardware intact, whatever. And so she actually was not having any symptoms, but the cage is the thing that worried me. And so we actually took her back, extended it, went above and below. And actually, in this case, I think Nujan talked about this, is, when do you quad rod, when do you put in extra, huh? Yeah.
Go back to your first slide.
Yeah.
Whoa. Keep on going. I think I had that much thoracic compression.
Huh? She had basically urinary retention and cauda equina. So yeah.
You got to be somewhat a little bit with urinary retention with acute fractures, because a lot of times, and I don't know about this lady, I'm making this as general.
Yeah.
Do a rectal exam. If you have a normal rectal exam, there's many other reasons for urinary retention, particularly with using morphine.
Yeah.
And the second thing is, a lot of these people won't push because it hurts their abdominal pressures when you get it. So when I was a junior person, we operated on 100 people because we did this whole thing with urinary dynamics. And one of the urologists came up to us and said, "You're an idiot. These tests don't work for people with acute pain because they won't push down to get their urine dynamics." So just, and I'm not saying this case, but like, she's an osteoporotic little old lady that lives on the edge. And we sort of found out we do a smaller operation in terms of she's going to die of titanium.
Yeah. Well, and she actually had she did have, cord swelling and T2 signal change in her conus. So, I mean, I think she did have an incomplete.
Yeah. I will tell you that I've moved away from corpectomies significantly. Yeah, I suspect that, so in my hands, if I were going to operate on this lady, I would have done a laminectomy. And then I can't see the pedicles. So when you do corpectomies, you lose your capacity to do index screws. So if you just do a laminectomy here, and depending on what those pedicles look like, you can often get 25 or 30 millimeter index screws, even at a level like that. And then I could even consider just doing T12 to L2 if I can get short index screws with a laminectomy, and try to avoid the downstream. So once you start putting cages and expandable cages, and the Hounsfield units of that bone are awful. I mean, L2 just look, both T12 and L2 are just asking for pistoning.
She made a stress riser, because if you look at her, she's fused, and you fuse to right to where she's, whatever, T12, 10, 11 is fused, right? So a lot of people use the thoracic spine, so you get a long lever arm.
Yeah.
And so you just use the 2 points, the only place you had to go was right at that place where she looked down.
Yeah.
Yeah, I mean, these are.
Hindsight's
Again,
2020.
Yeah. Yeah.
Yeah.
So she ended up getting, this larger surgery. And again, and I think this is another difficult case. You've got a T12, 66-year-old with a history of adrenal cancer. She's like 10, 15 years out. Increasing back pain and same, literally like just mirror image of the last case. So she's having increasing difficulty walking, and leg weakness, a little bit of incontinence, and that's what that looks like. Rakan, what would you guys do in McGill?
Well, probably we'd start off with restaging the cancer, a PAT scan, especially with the oncologist, understanding the treatment strategy plan. Operate exam, I don't know, there's some compression of the cornus there, so was there any rectal exam or PDR?
So she had this whole cancer workup. Everything was negative. She was admitted for increasing weakness, and conus, cauda equina type symptoms.
So as long as we document the neurologic compromise and decompression will be the next step. In my hospital, we almost never do corpectomies.
Okay.
Especially in frail patients. So probably just 2 levels above, below, and then try to distract with the laminectomy.
Okay, so you would do what David Okonkwo said, just a lammy with no screws?
No screws.
Oh, no, I didn't say no screws.
Oh.
2 levels below the laminectomy.
Okay, so no inner body, but you would just do a laminectomy. And David, you would do?
I would probably do the same thing that I talked about in the last case, and I would want to look at the pedicles to see if I can get at least 1 index screw, and just try to do. But this one might need 2 above, 2 below,
Okay.
instead of 1 above, 1 below.
What's that? Big operation, James. James changed his mind. Now he's more aggressive.
This one, the last one, you got a 9-year-old lady that's got a little.
No, she was younger. She was 61.
But I mean, this one, she's got a kyphotic deformity.
61 is not 90 in Seattle. I know in Philadelphia, 60 is like pull the plug, right? But man, they live to be 100 on the West Coast.
But I mean, this one to me is a total different animal than a lady with a fracture.
Okay.
This one's got an extension distraction almost type
Okay.
of injury. And she's lying down and she's not neutral.
Yeah.
I mean, so when she stands up, she's coming out. And then, I mean, it's just a total different beast.
So what do you think? T4 to pelvis, T10 to pelvis?
Oh, I don't think you have to go that far. I'd probably go 3 down, 3 above, and I'd probably drill the. I'd probably go
And
transpedicular.
corpectomy?
I'd go transpedicular and do just take the whole pedicle down, take the whole vertebral body out, and then just shorten her at that level.
You wouldn't put anything in there?
Yeah, so if you're going to put something in there, you can put a T-lift cage.
Yeah.
You don't need to restore.
Yeah.
You don't need to restore the height.
It's
Okay.
gonna as soon as you put her on the table, she's gonna jack down. I mean, this is actually easier than you think because her bone sucks. So it's all osteoporotic. You go in there and it's like butter.
So Charlie, what would you do in Baltimore?
3 above, 3 below.
Yeah, I would probably do 2 above, 2 below.
Okay.
With fenestrated screws, to help provide pull-out.
So you put cement in there too?
Yes, and I would do bilateral,
Okay.
second pedicles, and just push the fragmented bone into the humeral body.
Okay.
Use that as
Okay.
push the forward.
Okay, let's ask Dr. Mendel, the cancer guru. So what do you think, Uni? So James has completely he's 360 on us. He wants to go very aggressive. David is still doing his minimally invasive, and Charlie wants to go 3 above, 3 below. She's weak. She's got some Oskouian type symptoms. She's got difficulty. The minute she stands up, she like collapses. Surgery? What would you do?
So I, unlike common, a lot of people say she needs an anterior vertebrectomy. I don't go from the front. This is T12.
Yeah.
I'll do it all from the back.
Okay.
Yeah.
So
I'll
you would do
go-
corpectomy with
Yeah,
expandable
transpedicular
cage?
vertebrectomy from the back.
Sook did a study and
Yeah.
randomized them about 15, 20, I think he randomized them, but he did front, back,
Back alone, and it's almost the same, except for pulmonary complications. That paper changed the way I do these, because I used to always be like, it's a pretty hard operation
Yeah.
anteriorly to pull that, so the bone off.
Just take the entire vertebra out, just like what we did in the lab, but it's easier. It's not a non-blocker section. You can just walk slowly through it, find the edge between the dura and the bone fragment, walk at it, and try to push it all down. There's going to be once you get it all out, you can correct the deformity,
Yeah.
cut the nerve roots, and then put something there, whether it's a cement or
And
a
then
cage. Or
how
something
many, 3 above, 3 below?
I will go 3 above and 2 below.
Okay.
If it's big pedicles down there at L1, L2, I'll go 2 below.
How about
But you can go
Jens?
3.
Yeah.
So I'm stating the obvious. These are incredibly challenging cases in many regards. I haven't looked at all the studies, but I think that the initial hope is always to limit the surgery to like 2 above, 2 below. And despite my very adverse experience with cement that led to litigation and the loss of a patient life, I still think that a PMMA cementing of the UIV, LIV, and UIV +1 and LIV -1 allows a reasonable transition, and that's what I routinely do. My pulse rate goes high during the PMMA infiltration, and on my post-op CTs, I usually am happy when I see no cement evacuation, but sometimes it does filter out, so far without any harm since I've been here. But this is my attempt at trying to find a reasonable solution. I don't think that there's a simple other answer, because these patients are in misery. They can't get up and around. I actually had a patient with this who was neglected over a longer period of time, had a kyphoplasty attempt which failed, and her spinous processes actually rotted through the skin. This is a medical practitioner, so it's not just somebody.
Wow.
So she was so incapacitated that her spinous process actually formed a decubital ulcer that broke through the skin, the fascia, and everything. So this is something where we do have to try to come to grips with it. And again, the only other option is to go very long and do a thoracolumbar-pelvic fixation. That's, I think, still a bigger surgery than a cement-augmented procedure. Thank you.
Yeah, I just want to add that I've looked at my own series of, I think, 78 to 80 cases. cement versus cages, cement works fantastic for a lot of these cases. One of the issues is that in order to put a cage there, you got to get the end plate straight in the line. You got to correct it and all that kind of, intraoperative manipulation of the spine, which you can do. And then once you get the end plates aligned, you can get the cage in there. But on a patient with shorter life expectancy, where it may not mean as much, you can put the cement in there. It will fill up the entire space. And with cross compression across the cement, that should be enough. But this is, that's a long work. It's a lot of work here. That piece of bone is large, and you gotta make sure that it's not stuck to the anterior dura, because the worst thing that can happen in these cases is they have an anterior dural tear, and you can't fix it. It's very difficult.
So we ended up doing corpectomy, and like the last case, she had poor bone, but we got, I thought, pretty good correction. But again, like the last one, she failed pretty quickly. And this is her upright x-rays.
2 weeks.
Yeah. So, and again, I don't know, maybe not being as aggressive, because I do think when you take out all that bone, you do destabilize it, and, maybe 3 above, 3 below would have helped, but I was trying to do something smaller. And, she's had radiation, she's had adrenal cancer, so it's tough. And you can see that the hardware pulled out. That's what we ended up doing when we revised it. Here's another quick case. And again, this is just in the last couple months. So let me pick on someone, Clifford. So this is a 66-year-old who face planted after his wheelchair kind of got loose, and he went down like 20 yards and just flew off. And when he came in, he had a big goose egg on his forehead, and had a lot of neck pain, but otherwise was intact. So what would you do for this? Okay. Hit your microphone so we can hear you. So you see the odontoid fracture, I heard that. Just press the little button, it'll turn green.
Yeah, I see the odontoid fracture. So he's 66 years old. There's definitely misalignment there. I'd be concerned that it won't heal well for him.
And then what's that little piece of bone there that's that's around the odontoid that looks funny? What's that called?
Anteriorly or the tubercle? No.
What do you call that fracture there? It's named after a British neurologist, neurosurgeon.
Jefferson fracture, sir.
Who wrote 4 papers about this. Jefferson fracture, right?
At C1, yep.
Sir Jeffrey Jefferson. So, what ligament do you think he ruptured there?
I'd be concerned for rupture, definitely, of the TLL, the
Transverse ligament, right?
ligament. So.
Yeah.
So, hey, Rod, when you're done, I'll comment on this one, because this is actually probably a lot worse than I think.
You're going to operate?
Oh, this guy to me doesn't have a type 2 odontoid fracture. This guy actually has a dislocation of his neck. He doesn't have a Jefferson fracture because Jefferson described a axial load fracture that has 4 different parts of it, and he was a pathologist. But
this one does actually have 4 parts to it, so we just don't have all the cuts.
Okay. But it looks like to me the lateral mass is hanging off, and he's much more extended and distracted than you typically see in an odontoid practice. So to me, I would be very worried about doing a C1, C2 fusion on him.
What would you do?
I mean, I never do this, but again, we only get 2 pictures.
Yeah.
But I mean, to me, this guy's getting an occipital cervical fusion.
Really?
Which sounds crazy.
Wow, that's really aggressive.
I would wire. I would do harms and then wire.
Yeah, but I think your lateral mass is, and this is, again, I'd get the coronals because I think the lateral mass is off.
Yeah.
I think it's totally dislocated. I mean, this is a very scary fracture to me.
Types.
I'm all right with that, but it's a lot. It's sometimes when you get that C1 thing, it's like trying to hit a piece of Jello because there's nothing holding on to it.
Yeah.
So I mean, I think that's and I don't like. I've almost stopped doing occipital cervical fusions, and I've actually, believe it or not, gone back and taken occipital plates off 2 patients rather than fuse them to the occiput because I think it's probably one of the cruelest things we do to humans.
So we actually, so we did what Charlie suggested, and we did a C1, a C3 fraction. It was very unstable. We didn't go to the occiput, and we put, I think on these cases where you have a pretty severe C1 fracture, it's good to put a cross-link, one of those head-to-head cross-links, because it'll keep the, compresses it, and it keeps it from bowing. And then the other thing we do is, on this case, we got a little bit of a violation of the transverse ramen there, and we got an intraoperative CT scan, but we use these ACDF grafts, and we put it in the C1, C2 joint because it was so unstable.
Did you do that first, and then you drilled your screw hole?
We did no. We burred out the facet joints, took the nerve roots, and then distracted it open, and then placed the grafts.
When did you put your screw in? Or you distracted off your screw?
We distracted off our screws.
I was just thinking it might be interesting if you could
Yeah.
get that graft in, it holds it in place, right? Because you get
Yeah.
that distraction.
I mean, when we distracted it open, it was just fish-mouthed open. And then, in fact, I had to hold the C1 lateral mass to keep it from moving forward. But, I mean,
This is a great option.
Yeah.
This is also the correct operation for basilar invagination, by the way. You should no longer go to the occiput for basilar invagination. This is the correct operation for basilar invagination. And so that C1-2 interbody is a fantastic option and a fantastic tool to have in your tool belt. So you gotta do something more than C1-2 screws.
Oh, totally.
For this
Yeah.
case. This guy is too jacked up. So you either do that,
Yeah.
or you wire C1, but actually the C1 posterior arch was disrupted.
Yeah. I mean, it was all,
This is what you gotta
it was in like in 10 pieces. Yeah. And then the other thing I think about this case, and I'm doing this more and more, I wish I had pictures, but I put patients prone, and I use Gardner-Wells tongs instead of a Mayfield clamp. And it's amazing, like just even after putting 10 pounds on, you can literally see that odontoid just go straight up, you know? So I've kind of gone away. Jens and I kind of disagree a little bit, but I love to take the C2 nerve root and put people in traction intraoperatively, and to do it in a, not so their head isn't fixed, so they're prone, and they have a foam pad, and then you get traction on there as well. So
If you don't get your alignment with traction and the odontoid, the fracture piece still is kinked, would you change your operation if you can't get it correct?
usually these are so unstable that just by opening them up, detaching the muscles, distracting, putting in compression and stuff, usually it realigns. I haven't had, as these guys were saying, this is a wildly unstable fracture. It's the chronic ones that are harder to reduce, that kind of have that big pannus, and, they're kind of kinked back. Those are the harder ones to reduce. But this one is no problem at all.
Ron,
Yeah.
I just fear that for this kind of fracture, given how unstable it is, you're putting a lot of faith in the C1 screws here. I think that it's pretty mobile anyway. You've got
Yeah.
a nice reduction, but she's still got significant gap between the odontoid and the rest of the
Yeah.
C2. What would you lose if you went to the occiput? It's not that much more work, and she's already lost rotation, axial rotation.
Yeah.
Anyway.
I mean, it's a fair question. I don't know. I mean, I felt like we got pretty good fixation, and you can actually see the occipital condyle there, and there just wasn't that much instability at the occipital cervical junction. So, and we got pretty good, good purchase of C1. We put kind of long, and I always cut the C2 nerve root so you can really see everything. In fact, Dr. Moisey here published a nice paper about our technique and the two different ways. You can either go above, which is called the palm screw, or you can go from below and point up, and you can get, pretty significant. You can get like 30 millimeter screws in there, and about 22 to 24 millimeters of it is in bone. So I'm getting the signal to end. So that's it, guys. Thanks so much.